Hello everyone. Today we will discuss about the management of few of the commonest complications in cirrhotic liver disease patients, end stage liver disease. So here I will not be discussing in order actually. I will mainly focus on the management part. So we will begin now. First complication which we are going to discuss is about ascites. So commonly we see this presentation in case of cirrhosis or end stage liver disease. So what should be the basic steps of managing ascites? First thing, we have to advise to avoid NSAIDs and there should be salt restriction, that is to the extent of less than 2 gram per day. So this point we have to advise mainly to the attenders and the nursing staff to take care. Then we have to start on oral diuretics. Here usually what we can do is the initial dose, mainly we will use furosemide plus spironolactone. This all of you might be knowing already. So the initial dose of these two medication will be spironolactone 100 mg, furosemide 40 mg we have to start. Usually we will advise it to give once daily orally. This is the first point. Then once started on this diuretic, we have to monitor the individual's body weight ideally. So body weight. What we have to do is every day we have to monitor patient's body weight and our target should be to reduce minimum 0.5 half kg of body weight every day if there is only ascites, or if there is ascites plus pedal edema, it is recommended to target for up to 1 kg per day weight loss. So this has to be achieved using these two measures, the diuretics and the salt restriction. So every 3 to 5 days we have to keep on assessing. If we are not reaching these targets, we have to increase the dosage of diuretics. So every 3 to 5 days we can increase spironolactone to 200, 300 to a maximum of 400 mg. Here also it will apply the same 80, 120 till 160 mg. So 160 bar 400 mg is the maximum dosage of diuretics which we can try. So even with all these things, if the weight is not getting reduced as expected, we call it as refractory ascites. So this is the basic step we have to follow. Then coming to refractory ascites, as mentioned just now, if the individual is not responding to the oral diuretics, we can consider repeated large volume paracentesis. In the sense, what we can do is remove out up to 2 liters of ascitic fluid and we can give about 12.5 gram of albumin. We can give it after procedure also. Here the point to be stressed is many residents will be withholding the procedure of paracentesis just because there is no albumin to replace. But the fact is albumin has very long half-life, so it is not mandatory to transfuse albumin prior, then only we have to remove fluid, nothing like that. First you can remove out 2 liters of fluid, then also after the procedure you can give albumin. So this point is one of the practical tip for the residents. So this is about refractory ascites. And we know that if this one is also not working, there are next steps like we have to consider tips by referring to the specialists or liver transplant as the next measures. So some key points related to ascites are, if the individual of cirrhotic liver disease is having ascites, 2-year mortality will be about 50%. So this is very important when we explain the prognosis or the disease condition to the patient attenders. Then if there is associated hepatic hydrothorax along with ascites, if there is hydrothorax, it is an indicator of poor prognosis, that is a bad mortality predictor it is. And clinical important point is when there is coagulopathy like deranged INR and all, and thrombocytopenia, which is commonly associated in CLD cases. These are not the contraindications for paracentesis. This point has to be remembered. So we should not postpone or avoid the procedure if there are coagulopathy or thrombocytopenia. And we mentioned in the basic steps that we prefer oral diuretics. But you might be thinking about IV when we have admitted the individual. Commonly, we will start on IV diuretics. But remember, IV diuretics can precipitate renal failure. That's why if the individual is able to take orally, try to give oral diuretics only. And when to withhold diuretics. This point also is very, very important. So we have started diuretics for ascites, but we should know when to stop diuretics. If there is development of renal dysfunction, if there is hypovolemia, or if any electrolyte disturbance is noted in the individual, we have to withhold the diuretics and correct these factors. Then only we can restart the medication. So these are some key points which are very helpful practically. Coming to HRS AKI. So we know that now it is no more type 1, type 2. They have divided it into HRS AKI, HRS non-AKI. So mainly non-AKI in the sense, if the disease duration is quite longer, then we can consider it as AKD or CKD. So this part will not focus much as of now. We will mainly focus on HRS AKI, previously known as HRS type 1. So here, first of all, we have to know when to consider HRS AKI. Whenever, see, first point which is very important is patient should have liver disease, that is cirrhosis plus ascites. This is mandatory in all scenarios. So such individuals, we have to get basic or baseline creatinine first. So suppose there is an increase in the baseline creatinine by 0.3 milligram per deciliter in 48 hours, or if there is more than 1.5 times increase in the creatinine, that is nothing but by about 50%, we have to consider possibility of HRS AKI. It is just like the usual acute kidney injury criteria to consider it as HRS AKI as well. But the thing is, the individual should have cirrhosis plus ascites. And there are some particular factors before we call it as HRS AKI. That is, patient should not be in shock. So BP has to be maintained very well. And there is no usage of nephrotoxic drugs like NSAIDs or some aminoglycosides, antibiotics, diuretics, etc. And there should not be any structural kidney injury. So whenever we get this HRS AKI or renal dysfunction in liver disease patient, always get urine routine in which we look for proteinuria and hematuria. If proteinuria is there, it is indicative of structural, that is glomerular damage. Hematuria, again structural injury. And we have to get renal ultrasound also in which there should not be any structural problems. So what we can do in that case, we have to stop diuretics if the individual is already taking it, and we have to give albumin injection. So albumin has to be given. The dose is 1 gram per kg. Suppose the individual weighs 60 kg, we have to give 60 gram of albumin for about 48 hours. That is 2 days we have to infuse albumin. Then if there is no reversal of this value, that is if there is no reversal of AKI, then only we have to consider it as HRS AKI. What happens in majority of the individuals is they will get renal dysfunction, like we will observe raised creatinine. So we usually consider it as HRS AKI. But the thing is, we have to stop diuretic. We should start giving albumin for 2 days. Then you repeat the creatinine. If it normalizes, then it is not HRS AKI. If there is no response, then only consider it as HRS AKI. So this is the overall point. So all these factors should be considered. Now how to manage? We have seen that for 2 days we had given albumin and there was no response, right? So the treatment is mainly terlipressin. So here what we have to do, just remember simple thing, the dose recommended is 0.5 to 2 mg of terlipressin every 6 hours. So to simplify, we just consider the average of 1 mg. For example, 1 mg of terlipressin every 6 hours, in the sense 4 times a day. Okay. So this one we will start. Then we will follow the same thing for 3 days. So after 3 days, we have to analyze how is the resolution of AKI, that is HRS AKI. For example, in our patient, the creatinine is suppose 4 mg per deciliter, just for an example. So we have considered HRS AKI and the creatinine is 4 mg. We have started on 1 mg of terlipressin 4 times. So we are giving the same thing for 3 days. So after 3 days, there might be 3 possibilities. First one is there is no response at all, like the baseline creat, whatever 4 mg was there before initiation, it remains same. So this is considered as no response to terlipressin. So in that case, what we have to do, we have to consider other treatment options like commonly renal replacement therapy. This is first possibility. Second one is there will be very good response, in the sense this baseline creat will fall by more than 30%. More than 30% fall we can see by using terlipressin. This indicates a good response. There might be one more third possibility, that is there will be slight fall but not to the extent to call it as good response. So there will be fall but it will be less than 30%. So in these two cases we can increase the dose of terlipressin. We can increase the dose of terlipressin for a maximum of 2 mg every 6th hourly, like 4 times a day. So we have to keep on giving this terlipressin till the creatinine reaches 1.5 milligram per deciliter, and this has to be confirmed twice, at least 2 hours apart. We will send creatinine repeatedly. If the values are normalized, then we can stop terlipressin, or else maximum for 14 days we can try with terlipressin. So even after 14 days, if the values remain above normal range only, then also we can consider other modalities of treatment. So these points are very, very important when we are treating HRS AKI. And it is also important to know when we should not give terlipressin. Suppose the creatinine is more than 5. In our example case, we gave it as 4. So if it was more than 5, don't use terlipressin. If the saturation of the patient is less than 90%, or if there is any history of coronary ischemia or peripheral ischemia, mesenteric ischemia, we should avoid this particular medication. So in that situation, what are the alternatives? This also is very, very important, because sometimes there will be contraindication like just now mentioned, or patient side will not be affordable for terlipressin in Indian setups. So in that case, we have to know what are the alternatives. So we can utilize noradrenaline, dosage is mentioned here, or midodrine tablet 7.5 to 15 mg orally 3 times a day we can give, or octreotide, again TID. So these are some alternatives for terlipressin. As mentioned, if the patient is not responding to the above steps, or if the individual is critically ill with volume overload, we have to consider renal replacement therapy. Next complication of chronic liver disease will be spontaneous bacterial peritonitis. So whenever we think of spontaneous bacterial peritonitis in liver disease patients, that is if there are clues of fever, abdominal pain, rise in total counts, etc., we have to think of SBP without fail. So first we have to prove it, that is we have to send ascitic fluid analysis, and there should be more than 500 cells in total, and among them neutrophils should be more than 250. This is the point to consider or to prove SBP. So once it is proven, what we can do is we have to start on antibiotics. Preferred ones are cefotaxime 1 gram IV TID, or ceftriaxone 1 or 2 gram IV once daily. So this antibiotic should be given for 48 hours. Then what we have to do, we have to repeat ascitic fluid analysis again. So once we repeat it, the neutrophil count, whatever we had got, for example, it was 300 suppose in the first value. After 48 hours of antibiotic, there should be fall of neutrophils by more than or equal to 25%. So if we see such response, if there is yes, like it has responded, we can continue the same antibiotic for 5 days or 7 days. if there is no proper response, in the sense no fall in the neutrophil to more than 25%, in the sense if there is no good response, we have to think of multi-drug resistant organisms. So we have to consider change of antibiotics to the broad spectrum ones like piperacillin, tazobactam, meropenem, vancomycin, etc. based on the suspected microbe. So these are the things we have to follow for spontaneous bacterial peritonitis. What about prophylactic antibiotics? Is there any role to start prophylactic antibiotic in a patient who has presented for some other complications of liver disease? Yes, there is definitely a role of prophylactic antibiotics. Suppose if there is evidence of varicella bleed, or if there is any history, prior history of SBP. Otherwise, when we send ascitic fluid analysis, if the absolute protein level are less than 1.5 gram per deciliter, they will be at risk of developing SBP. So we can give prophylactic antibiotics in that case. Or there are some other parameters also, like bilirubin of more than 3, sodium less than 130, or blood urea nitrogen of more than 25. In these cases also, we can give prophylactic antibiotics. Sometimes, along with this infection, patients will develop renal dysfunction. In that case, first thing is discontinue diuretics, as mentioned previously. Start giving IV albumin infusions. So in that situation, we have to give about 1.5 gram per kg body weight of albumin on day 1, followed by 1 gram per kg of albumin on day 3. So these things should be followed when there is both complications, SBP plus renal dysfunction. Then comes hepatic encephalopathy. So in this case, we have to search for the precipitants leading to encephalopathy. Commonest ones are infections, dehydration. This is very important because we often overlook this condition. Or there might be GI bleed, constipation, even hypoglycemia. So in that case, because of gluconeogenesis, protein utilization, there might be increased production of ammonia. So these are some precipitants. So what we can do in that case, we have to utilize lactulose about 30 ml every 2 to 8 hours, or even enema we can utilize, so that the individual will pass at least 2 to 3 episodes of stools. So 2 to 3 times the individual has to pass stools. So along with lactulose, we have to utilize non-absorbable gut targeted antibiotic, that is rifaximin 550 mg BD. So these two are considered as gold standard treatment for hepatic encephalopathy. Few practitioners use LOLA, that is L-ornithine L-aspartate. It is a metabolite in the Krebs cycle, so that it will lower the production of ammonia. So we can utilize this. The dose is 6 mg tablet 3 times a day. But the thing is, avoid this particular medication if the creatinine is more than 3. And very important thing is evening carbohydrate snacks. If the individual is able to take orally, advise them to take carbohydrate rich snacks during evening, because during night time, because of non-feeding, there might be again utilization of protein leading to excessive ammonia production. So advise the attenders not to miss carbohydrate snacks during evening hours. Otherwise, we can give dextrose rich fluid like 25% dextrose in the evening without fail. We can add even thiamine or multivitamins in this dextrose. Commonly, whenever we write treatment chart for such individuals, we will be giving thiamine dextrose, but we will write it in the morning or afternoon. So make a habit to write it during evening hours as well. It is very, very important to give carbohydrate snacks during evening. Next complication is about varicella bleed. So whenever there is bleed, first priority is again protection of airways. If this bleeding has led to shock, preferably try to replace PRBC, and in this case we have to give prophylactic antibiotics, which just now I have discussed in the SBP section. And we can utilize a medication that is octreotide. So the dosage, I hope majority of you might be knowing, 50 microgram IV bolus followed by same 50 microgram per hour IV infusion should be given. and advice for endoscopic ligation and sclerotherapy. Overall, the thing is we have to stop bleeding somehow. So once by all these measures bleeding stops, always start on beta blockers. That is propranolol, carvedilol or nadolol can be utilized. Here comes a special point. So students or residents usually start on beta blockers, but they will not be knowing how to titrate or how to monitor. One important point to monitor here is focus on heart rate. So the target heart rate should be 55 to 60 beats per minute. So till this target heart rate, we can increase the dose of these beta blockers because they will be very effective in maximum tolerated dose. Not like just we will start propranolol some 20 mg once daily and it will be helpful. Don't consider such initial dosage are enough for these individuals. Always remember we have to keep on increasing the titrating the dose to reach this particular heart rate, because what we have seen is many of us will be in an inertia because we will be afraid of bradycardia particularly when we start beta blockers, but that is not the point. The target heart rate you have to remember, according to that we can increase the dosage. This is for varicella bleed. Other general guidance when we get case of liver disease is, see, for coagulopathy we have to prefer FFP, PCC or cryoprecipitate. So these are preferred over vitamin K. Residents commonly write vitamin K injection whenever they get a case of liver disease. But remember, it is not helpful because in liver disease, it is a problem of synthesis of clotting factors. Synthesis of clotting factors, because liver is the one which is helpful in producing 2, 7, 9, 10 clotting factors. And vitamin K should be given only if there is deficiency. So in liver disease, usually there will not be deficiency of vitamin K unless there is obstructive component. Obstructive component, in that case, because of the obstruction in the biliary tree, there will be improper absorption of vitamin K. So in that case, we can give vitamin K. But otherwise, it is not required to replace vitamin K because it is a problem of synthetic dysfunction. This is again very important point to focus upon. One more drug which we often enlist in CLD treatment is ARASU-MEDPEDS acid. So again remember, it will be helpful in sequestering bile in the biliary tree. So whenever there is obstruction again, then only you try to wash it out using this particular medication. And majority of the times, few people, even though there is normal bilirubin, no features of obstructive jaundice, even then we will keep the patient on long-term ARASU-MEDPEDS acid, which is not a good way of practicing. So just remember this point. And as mentioned, evening carbohydrate snacks, majority of the times we will not be focusing upon this. So try to inculcate this particular point in treatment of CLD. When it comes to protein, the recommended protein intake for even liver disease, end stage liver disease individuals, because they will be malnourished, is 1.2 to 2 gram, just like the normal individuals only. But here, just because protein is helpful, don't prescribe some random products, mainly the unchecked protein powders. Here, try to advise them to take egg whites, or you have to see the labeling of the protein powder if you are prescribing one, and it should be rich in branched chain amino acids. So this point you have to verify as being a responsible physician. Don't just randomly prescribe any protein powder, which will be majority of the times they will be filled with amino spiking, in the sense not a good quality of protein is used in majority of the protein powders. So this point is very important. Please check, there should be predominance of branched chain amino acids whenever you are writing a protein powder. Otherwise, just advise them to take egg whites and the natural forms of proteins. This is the overall point. Then one more situation is hypoxia in these patients. So we have to know some causes of hypoxia. So whenever we get hypoxia in these individuals, often consultants will ask what might be the possibilities. So remember, it might be because of refractory tense ascites, because of the decreased respiration there might be hypoxia, or hepatic hydrothorax, as mentioned in the beginning, it is a poor marker or poor indicator, poor prognostic marker. Or there might be chances of hepatopulmonary syndrome. As you know, liver will be detoxifying some of the toxins. If liver is injured, these toxins will reach pulmonary circulation and it will cause abnormal vasodilation there. This is a possible mechanism, and the commonest features are orthodeoxia. That is, patient will desaturate if they sit upright, and they will be maintaining saturation when they are in supine position. This is one of the hallmark of hepatopulmonary syndrome. Treatment for this is transplant only. And there are some other possibilities like pneumonia, commonest. The patient will be in the hospital, so there might be chances of hospital acquired pneumonia, etc. Or there will be concomitant lung disease as well. For example, COPD. So these are all the possibilities to consider whenever there is hypoxia.